Class, we're going to talk about the very important concept of oxygenation. And as you can tell from your handouts, this is defined as the mechanism that facilitates or impairs the body's ability to supply oxygen to all cells of the body. The function of the respiratory system is to obtain oxygen from atmospheric air, transport this air through the respiratory tract into the alveoli, and ultimately diffuse oxygen into the blood to carry oxygen to all cells of the body. When oxygen status changes, patients will show signs and report symptoms to a healthcare provider, and these alterations can have serious consequences and should be addressed immediately. And I've talked all along about the importance of each of these concepts, but I probably would have to say that this is by far the most important concept, because without a properly oxygenated patient, your patient's going to have serious consequences, as this definition states. And we as nurses need to recognize these changes very quickly, because some of these patients can spiral downhill very quickly. So again, assessment is huge, and much of this assessment can be made visually. You can walk into your patient's room and look at your patient and right away assess things like his color, how fast he's breathing, when he's talking, is he extremely short of breath. You can look at symmetrical rise and expansion of the chest. These kind of things are really important to note. Does he have oxygen on? And to definitely assess at what type of modality does he have on. Is it cannula? Is it a mask? And then to be sure that the patient is being delivered what has been ordered by the healthcare provider. We have other tools in the healthcare profession to assist us in making assessments about our patient's respiratory status, and I will get into that a little bit later. That's that section in your concepts book labeled diagnostic studies, and I didn't have you read that because some of that is a little more complex, but there are some very important information within that those few pages to point out, because some of the tools that we use, such as pulse ox, chest x-ray, all those things will give us a clearer picture on what could be possibly causing our patients to have alterations in their oxygenation. So what I'm going to start off with now is just to kind of have you maybe close your eyes and think about that continuum again for oxygenation, where you have a patient at one end who has serious compromise in their oxygenation, and that is represented by very, very fast and labored respiration, someone whose color may be even dusky to cyanotic, really having a really hard time breathing. Their general overview of health is extremely poor, very similar to the case study that I'm going to do with you. So then we have the patient on the other end of that spectrum who really presents in a way that you can definitely assess that he's oxygenating good, color's great, respirations are within normal range, and you can just tell by looking at the patient that oxygenation is definitely not his problem. So there are those looks on the spectrum with a very positive appearance, and then the opposite, which would be a very negative appearance, where there is some very, very severe alterations in regards to the patient's oxygenation. So here in front of you I have just a nice organized PowerPoint that just talks about the concept of oxygenation, and all this pretty much follows your reading in your Pearson concept book. on this page I have many of the concept learning outcomes that are in your book that are very similar to the ones that are actually in your weekly lesson plan that I hope you are able to acquire as you read and learn and review the many, many important issues associated with the concept of oxygenation. Many of these terms, anatomy and physiology, will definitely be a review, but I think it's important that you again focus on how the normal process of oxygenation works for any person, so that when we talk about the abnormal, it makes a lot more sense, especially this week as we begin to auscultate and assess our patients' breath sounds. It will be very important for you to understand what those breath sounds mean when you can pinpoint and kind of differentiate between what kind of breath sounds that you're hearing. Because each one of those, which we call adventitious breath sounds, meaning abnormal breath sounds, could alert you to the possibility of a particular diagnosis with your patient. So that's why I think it's really important that you review this system, because it is very complex, and this is a system too that is just not involved with the lungs. There's many other structures in the respiratory system which provides us with the oxygen that we need, and when any of these structures may have some kind of impairment or have barriers that prevent the diffusion of gases and prevent from taking in that oxygen, we're going to have patients that are going to be starting to show and demonstrate some difficulties. And the important thing behind that is to be sure that we can assess those abnormal findings as soon as possible before the patient gets into any more trouble. Because think about it, without oxygen and for any period of time, there are severe consequences that go along with alteration in oxygen or a deprivation of oxygen. So here we have the concept of oxygenation. Oxygenation is the process of providing oxygen to all cells of the body, and this is just a summary of what is the function of our respiratory system. It is to obtain oxygen from atmospheric air, it's to transport air through respiratory tract to the alveoli, and it's to diffuse oxygen into the blood to be carried to all cells of the body. Okay? And think about those two terms, which we call inspiration and expiration. And the respiratory system does achieve all these processes through ventilation, which does include both inspiration and expiration. Inspiration is just a fancy term for inhaling, and expiration is just a fancy term for exhaling. And respiration is the exchange of oxygen and carbon dioxide at the cellular level, and this term is commonly used synonymously with ventilation. Okay? And respiration technically refers to that exchange of oxygen and carbon dioxide at that cellular level, as I said before. And breathing is typically an autonomic process. We breathe without even thinking about it. We talk and we breathe at the same time without even thinking about it. And as I said earlier, alterations in that breathing pattern should definitely be immediately addressed to prevent any severe complications or consequences from occurring. And normal oxygenation depends on two factors: healthy development and function of the respiratory system, and intricate cellular and organic processes that allow for effective gas exchange. And from there, we're going to look at some of the specific structures in the respiratory system and kind of review their particular function and job in providing your patients in properly oxygenating. We can kind of divide the respiratory system in the upper respiratory system and the lower respiratory tract. And in the upper respiratory system, there is an inlet for air into the body, and that happens primarily through the nose. And it is typically that primary organ that allows entry for air. We have two nares, which warms, humidifies, filters air as it is breathed into the nose. And we might not think this is a very important function, but it truly is, especially for patients that are susceptible to respiratory conditions, that already have chronic respiratory illnesses. It's very important that, particularly when they're out in the cold atmosphere, that they really breathe through their nose first, so that air is warmed up and doesn't cause any irritability to the delicate tissues in the lungs. Sometimes with patients who might have a history of asthma, which affects the bronchioles and can cause bronchial constriction or cause those bronchioles to kind of close up. If a person breathes in cold air, maybe starts breathing in through their mouth rather than through their nose, it could set off some type of asthmatic reaction. So that's why looking at the nose, it's very important that the nose is structurally in sound or intact and that it's functioning properly. That's why part of that assessment, when we looked up into the nares, that we didn't see any type of obstruction, that we wanted to be sure that it was patent, so that as we take in oxygen, we can bring that air into the lungs through the nares, which provides those all-important functions of warming, humidifying, and filtering the air. And our nose also has protective mechanisms, such as sneezing, because some irritable particulate that gets into the nose, we sneeze and we kind of blow out that particular irritant, so it doesn't get down into the lungs and cause problems. We have cilia, which are those microscopic hairs within the posterior portion of the nares that actually trap small particles of foreign matter to prevent their entry into the lower respiratory tract. And the cilia can also propel foreign matter into the pharynx to be coughed out or actually swallowed. So that's a really important function. And when we look at people who have had damage to their cilia, say people that are long-time smokers, that cilia can be damaged and no longer exist, so they lose out on that very, very important protective measures of the upper respiratory tract. Breathing can also occur through the mouth. It allows air to enter the respiratory system through that pharyngeal cavity. That's another reason why we look into the pharynx to assess any type of obstruction, swelling, inflammation, edema. And the respiratory system shares this cavity with our GI system, providing passage for air during breathing, and for food or drink during swallow. However, remember, think about other structures such as the epiglottis, prevents those foods and fluids from passing through the glottis, which serve as an entryway into that lower respiratory tract. So that closes up when we're eating or drinking, so we don't aspirate and pull in those particular foods, either solids or liquids, into the lungs. Remember, the epiglottis is somewhat of a pendulous tissue that actually covers the trachea opening during swallowing or any time foreign matter contacts the glottis. And the closure of the epiglottis is a reflective response. So think about how important that is. And we know that kids, when we talk about some of these age groups across the lifespan, some of these kids ends up end up with epiglottitis, which is an inflammation of that, which can really cause a child to have stridor, wheezing, and really can be a problem when it's unhealthy, diseased, or suffering from some kind of infection or inflammation, which can actually close off the airway. So that's why kids are very prone to those kind of problems when they get a cold or a sore throat. All right, now we kind of talked about the upper respiratory system. Let's kind of move down to the lower respiratory tract, and that's definitely enclosed in the neck and the thoracic cavity. And think about our trachea, which sits midline in the neck. It is the entrance for air into the lungs, okay? And during normal breathing, the muscular structures of the neck are relaxed, and the larynx easily rises and falls with each time that we swallow, okay? And then the chest wall will effortlessly and symmetrically rise and fall with each equally spaced breath that we take. And so inspiration is half the rate of expiration, and eupnea describes breathing within the expected respiratory rates. And we use the term auscultation, which means that we listen to the body sounds with a stethoscope, and it is truly a very, very important assessment method that we use, okay? So right here on the screen, we kind of see when we talk about the term eupnea, that's breathing within the expected respiratory rates. And we have all these various age groups across the lifespan about what would we see as a normal respiratory rate for those particular age groups. And as you can see, newborns really do breathe a lot, 30 to 80 breaths per minute, infants 30 to 60, toddlers 20 to 40, preschoolers 22 to 34, and school-age kids 15 to 25, and then adolescents. We started seeing it slow down a little bit, where adolescents are 12 to 20, adults 12 to 20, and older adults are about 15 to 20. So this is why it's very important to kind of have a general idea of what the norm is for each individual age group. Because obviously if a newborn was breathing 50 times a minute, that wouldn't be anything to be concerned about. But if it was a adolescent or even a school-age kid, we would be very concerned, because obviously they shouldn't be breathing any more than 20 to 25 times a minute. All right, we're at the trachea, and remember how it bifurcates into two bronchi to access the right and the left lungs. The right bronchus is a little shorter than the left, and the bronchi divide into bronchioles. Those are smaller tube-like airways, and the trachea and the bronchia are supported by cartilage rings, and the bronchioles are supported by smooth muscle. And remember, as we look at the bronchioles, they are supported by smooth muscles only, and they can dilate and constrict in response to autonomic nervous system regulation of those smooth muscles that support them. So many times if our patients, and this is where the disease process of asthma takes place in the bronchioles, so we give medications that help to bronchodilate and kind of counteract the inflammatory process and the hyperresponsiveness that may happen when a person has an asthma attack. So remember, that is, since they're muscles, they're definitely controlled by the autonomic nervous system and can have the ability to dilate and to constrict. And Remember, bronchioles then give rise to the alveoli ducts, which branch into the alveoli sacs that are made up of individual alveoli. And if we talk about alveoli, we can kind of compare those to these grapes and membrane-like structures, okay? And alveoli, this is a very important part of how that respiratory system works, is that alveoli are the sites of gas exchange. This is where oxygen diffuses across those membranes into blood, and this is where carbon dioxide also diffuses into those alveoli, okay? And remember, the alveoli is that terminal or final structure of the lower respiratory system. And again, to definitely stress what exactly is those alveoli do is they serve as the sites of gas exchange, especially carbon dioxide and oxygen. They're not directly connected to any specific bronchiole, but are interconnected to the terminal airways and to each other. The structural design facilitates the filling of each alveolus with air, and there are specialized cells within that alveoli that produce what we call surfactant, okay? So let's continue with our anatomy and physiology review. Remember, surfactant is which controls that surface tension, and in turn keeps those alveoli from collapsing and sticking to themselves. All right, so that's what surfactant does. And there are what we call macrophages within those alveoli, and they keep the alveoli region free of microbes and are swept upward from the alveolar region by cilia in the airway passages. And remember, these macrophages are large cells of the immune system that remove waste and harmful microorganisms from the alveoli and from other areas of the body. Mast cells in the alveoli mediate the immune response within the airway. Also think about then the lungs. They're very much described in terms of their lobes, and the lobes lie obliquely in the thoracic cavity. And if you look on your concepts book on page 1023, you'll be able to look at the lobes, and then there's kind of a picture that shows a more intricate detail of the different layers in the lungs, okay? The right lung has 3 lobes, and of course the left lung has 2 lobes, all right? And the right lung has, as I said, 3 lobes, and the inferior lobes are the largest. Inferior means they're the ones at the bottom of the lungs, okay? Most of the inferior lobes lies in the posterior thoracic cavity, and remember, each lung has a pleural lining to aid respirations and to separate it from the other lung. And remember, that pleural lining has 2 different types of layers. We have first the visceral pleural, which covers the surface of each lung, and then we have the parietal pleural, which lines the inside of the chest wall. And then between those is just a tiny amount of fluid between the visceral and the parietal pleural, and that's what allows these structures to kind of glide and slide across one another without friction during inhalation and exhalation, okay? And that region between that visceral and parietal pleural is called the pleural space, and this is very important to remember this, because that's normally how the structure should be. But sometimes our patients, due to some kind of disease process that's occurring in the lung, may develop what we call a pleural effusion, and they might have an excess amount of fluid in that pleural space, and this would be evident on a chest x-ray, and obviously by the symptoms your patient may be displaying. Might be more short of breath, and think about it, the more fluid that's in that pleural space, it's going to be harder for inhalation and exhalation to occur, okay? because the lungs can't expand as readily. All right, so that's kind of a quick overall of the respiratory system, starting with the upper respiratory system and then finally ending up in the lungs. We now want to kind of talk about breath sounds, because this is where we're going to begin that assessment this week in lab to assess our patient's chest anteriorly and posteriorly, because breath sounds can really tell us a lot about our patient's present status in their respiratory system. And really the quality of those breath sounds, or what we're actually hearing, depend on the site of where we're listening to, or the site of auscultation. And what do I mean by that? For example, if we have normal sounds, and these are called bronchial sounds, and as the slide says, they're very loud, high-pitched, and they're heard over the trachea, all right? And bronchial sounds are longer on exhalation than inhalation. Now, I'm not going to ask you these kind of questions, because that's the first thing a student will send me back an email and say, hey, do we have to know this? This is stuff you should already know. You already have this in A&P, but it's good to kind of process again, because some of your patients, are going to have no problems with their breath sounds, but this is just the normal art of breathing. And when you listen to these breath sounds over the trachea, you're going to hear what we call bronchial sounds, and the sounds are much longer on exhalation than they are on inhalation, okay? And then the next type of normal breath sounds are called bronchovesicular sounds, and those are medium in loudness and pitch, and they're heard on either side of the sternum between the scapula, okay? And the inhalation, the exhalation time are both exactly the same. So we hear it with no evidence of any respiratory distress. And then the last type of normal breath sounds are what we call vesicular, and those are soft, low-pitched breath sounds that are heard over the peripheral lung views, kind of on the bottom. And those are most prominently heard in the lung bases, okay? And typically it's longer on inhalation than exhalation, pretty much the opposite of our bronchial sounds, okay? So those are just what we call normal or ventitious breath sounds, when, there's absolutely no disease process occurring, or the patient's in no type of distress. If you were just listening to somebody's normal breathing pattern, these are the normal or ventitious breath sounds that you would hear, called bronchial, bronchovesicular, and vesicular sounds. And then this slide kind of just gives you a brief definition of what kind of sound it is, and how it's related or how it's presented within inhalation and exhalation. This is a really important, concept or fact concerning our respiratory system. But the drive to breathe depends really on our level of CO2 in our arterial blood. When that level rises, there's receptor sites in our medulla or in our brain and pons that stimulate to increase rate and or depth of ventilation. Because why that does that is because the brain will tell us to breathe faster and increase that rate, so that we'll blow off that CO2, because a high level of CO2 can be very, very dangerous. So we also look at the quality of breathing, that effort that's used to take in a breath, the sounds that occur. And of course, in order to breathe effectively, we must have a patent airway, open and free of obstruction. And obstruction may not necessarily be a foreign body. It could be a lot of mucus, something like that, that definitely obstructs that airway, that prevents air getting in and reaching those alveoli for a proper oxygenation. We also have what we call receptor sites that are in the aortic arch and the carotid arteries that monitor O2 levels. They induce inspiration when levels fall below normal, okay? And the ability of the respiratory system to deliver O2 depends on very well oxygenated alveoli, very well inflated alveoli, and well perfused capillaries, okay? And that movement of O2 across alveoli, capillary membranes, into capillary is represented by ventilation perfusion, or a VQ ratio, okay? That's really important because we are going to talk later on, and you're going to learn in some of your classes later on, that a patient who might have a ventilation perfusion problem, this will definitely be altered. And an example of that would be someone who has a pulmonary embolus or a blood clot in their lung. That VQ ratio is definitely going to be impaired, okay? So we're just looking right now at the normal, but you have to understand that. So when you understand how this movement of O2 across that alveolar capillary membrane is represented by that ventilation perfusion, or that VQ ratio, there should be a certain concentration of oxygen and carbon dioxide that dictate that movement across that membrane. But many times our patients will have some kind of illness or defect that cause that VQ ratio to be abnormal. So that's why this is really important that you read this over again and kind of understand this A&P, especially when we're talking about CO2 levels, because that's another thing that's going to come back and have you understand how the disease of emphysema works, because these people already live in a chronic state of high CO2 because there's a poor exchange, because the alveoli is definitely impaired due to all the damage done by cigarette smoke or whatever caused their emphysema. So this is why we are very careful that with a COPDer we don't give them too much oxygen, because we don't want to lower that CO2 very much, because that's what keeps them breathing. So that's why these normal functions are so important to understand, so that when we learn about some of the exemplars that explain the alteration in oxygen, you'll understand why, because now you'll remember that, the drive to breathe depends on that level of CO2, and I've got receptor sites in the aortic arch and the carotid arteries that monitor O2 levels, and when that O2 gets low, that induces inspiration. And an example of that would be someone who has sleep apnea. What happens to these people during sleep? They go to sleep, and for whatever reason, their O2 levels start to drop, and these receptor sites in the aortic arch sense that O2 dropping, and it kind of wakes the person up and says, you need to breathe because your oxygen levels are getting too low. So that's why that works for a person. And again, understanding that movement of O2 across that alveoli capillary membrane. I can't stress the importance in really going over these and thinking about, okay, yeah, that's how that works with my patients, because when any of these are not functioning at their capacity, we're going to have our patients start to exhibit signs of alterations in their oxygenation. Okay? These are just, now we're looking at those alterations in oxygenation. We look at that term hypoxemia, which is just decreased levels of O2 in the blood, and left untreated can result in hypoxia, in which now we have a decreased delivery of O2 to the tissues. And our thoughts are, when we see that our patients are starting to develop hypoxemia, we need to fix it as soon as possible. And we also have to think about why it's occurring, because look what the consequences of hypoxemia lead to. It leads to a patient becoming hypoxic, which causes a decreased delivery of O2 to the tissues, which you'll then start to see organs start to fail, heart, lungs, brain, and kidneys. So that's why we need to correct them before we end up with a patient who we are unable to reverse, unfortunately, the effects of hypoxemia. So think about what that means. I mean, you can learn a definition, but now I want you to think about hypoxemia. Why is my patient hypoxic? Why are they suffering from hypoxemia? And when hypoxemia or hypoxia results, what am I seeing in regards to my patient's mental status? How is their heart working? Is the heart more? Is the heart rate faster? Is the respiratory rate faster? What's my patient's kidney function? So these are things that you definitely want to think about. These are sometimes the first signs of impairments in oxygenation. Patient may begin to become fatigued, irritable, or just face general discomfort. And more severe alterations can be fatal if left untreated, because these will start to deteriorate if you don't do anything about it, okay? But yeah, we may temporarily put on some oxygen, but that doesn't fix what the problem is. And our goal is to continue to assess, report findings to the healthcare provider, and find out what is the etiology or the reason why your patient is becoming, hypoxemic or starting to develop these signs of impairments within oxygenation. And of course, alterations in oxygenation described in content of gas exchange, airway patency, and of course we look at our patients' respiratory patterns. Is there damage to supporting thoracic structures can also interfere with effective respiration, or irritation or inflammation of respiratory mucosa affects oxygenation. So it might be to the fact that damage to some of these supporting structures could be due from a patient's long-term COPD, causing that rib cage to be pushed out, thus causing damage to those supporting structures. And irritation or inflammation could be done due to patient develops bronchitis, patient develops some type of respiratory infection like pneumonia. That definitely will interfere with oxygenation. I'm not going to get into a lot of detail with gas exchange. Again, we talked about how that level of carbon dioxide in arterial blood is a primary stimulus for ventilation. We'll get more in detail about that in 8B when we actually look at arterial blood gases, okay? And understand why those alterations and conditions occur within arterial blood. I think too, looking at some of the terms with some of the structures that may be damaged. We might talk about damaged alveoli, and that also occurs when our patients have a COPD or emphysema. And that's why we might see our patients and even children develop serious problems when we look at that chest movement and look at that expansion of the chest. Some of our kids who might be in severe distress due to infection, due to whatever the problem may be, may suffer from what we call retractions, which are manifested as drawing in of the chest wall, and those are really ways in which we're kind of clued in that the patient is definitely hypoxic. Or when we look at color, cyanosis is a bluish discoloration of the skin and mucous membranes, and this is what we call a late sign of hypoxia. In individuals with darker pigmentation, remember we talked about this, cyanosis may be presented as gray discoloration of the skin. And an indicator of chronic hypoxemia is club nail beds, and club nail beds have an angle of 180 degrees or greater, depending on the duration of the time an individual has had hypoxemia. So these are other clues and other assessment findings that tell us that your patient is suffering from hypoxemia. Okay. And as I said before, when we talked about VQ ratios, airflow in that alveoli is blocked by sputum, inflammation, swelling, atelectasis, or fluid volume excess can cause decreased ventilations, and things like blood clots, plaque buildup, and emphysemic alveoli interfere with capillary blood flow. Okay, so this is where you might see that mismatch of those VQ ratios. Okay, as we talk about airway patency, that, as I said before, can result from increased sputum, from the upper and lower respiratory infections or irritation. So that's why when a patient is presenting with very thick sputum, it's a very concerning problem, because it can block large and small airways, okay? And along with patients developing some infections in the respiratory structures, it also comes with inflammation, which narrows those airways and decreases the movement of air through the respiratory system. And airway obstruction is the primary cause of atelectasis, which, as we talked about before, refers to the collapse of all or part of a lung, affecting the exchange of oxygen and carbon dioxide. So that's what airway patency is all about. And then lastly, we look at respiratory patterns, and respiratory rates, rhythm, depth, and quality demonstrate adequate oxygenation to the cells. So any type of respiratory rate that's greater than 20 is called tachypnea. And things like anxiety or stress can cause an individual to breathe very rapidly. They start to inhale and exhale very deeply, and we call that hyperventilation, and that's a very rapid and deep inhalation and exhalation of the air from the lungs. When someone is hypoventilating, meaning that there is a very slow respiratory rate that leads to inadequate oxygen delivery to the lungs, as well as an increase in retention of carbon dioxide. That might be a respiratory rate of less than 10 breaths per minute, and we call that bradypnea. And respiratory arrest is characterized by somebody who has what we call apnea, and that is the absence of breathing. Okay. Another word that we use is called dyspnea, and that's labored breathing or shortness of breath that is uncomfortable or painful. And that's also when breathing is not sufficient enough to meet those oxygen demands. Many times our patients, because of their lung problem or respiratory problems, may demonstrate exertional dyspnea. Maybe with activities, they're fine, they're not very short of breath when they're in bed, but all of a sudden they have to get up, and all of a sudden now they feel very dyspneic or very short of breath. Okay, and that's kind of a fancy term for shortness of breath. So we see all different degrees of dyspnea, mild to moderate. We might see somebody with extensive lung problems who just sits on the side of the bed in severe dyspnea, even at rest. Orthopnea is difficulty breathing when the person is lying down, and several breathing Several breathing patterns with irregular rates, rhythms, depths, and quality indicate abnormalities within the other body systems. We can also look at giving names to to specific respiratory patterns, and one of them is Kussmaul breathing, and this occurs in the presence of metabolic acidosis, and it is characterized by very deep and very rapid breathing. And these deep, rapid exhalations increase the elimination of carbon dioxide, and that will affect definitely acid-base balance or CO2 levels, all right? Then we also have another one called Cheyne-Stokes respirations, which exhibit as deep, rapid breathing and slow, shallow breathing with then periods of apnea, okay? And we see these types of respirations in individuals with congestive heart failure, increased intracranial pressure, and people that have drug overdoses. And then another one is called Biot respirations, and these are seen in individuals with central nervous system disorders. And these are characterized as very shallow breathing with periods of apnea, okay? And as a result of central nervous system effects, medications such as benzodiazepines, barbiturates, and opiates may cause respiratory depression, a decrease in the depth and rate of breathing. That's why it's so important that when we give narcotics, which will definitely affect the central nervous system and affect the respiratory rate, we always be sure we don't sedate our patients too heavily, or we will cause respiratory depression. So those are some specific respiratory patterns, and it's important that you know those. So they were Kussmaul breathing, Cheyne-Stokes breathing, and Biot respirations. So I want you to review those and understand, because you'll see those again, and you're going to see patients demonstrate those, especially when you get to the more complex med-surg courses that you're going to take. You're going to see patients in critical care exhibit these types of breathing patterns. Okay, very important to know. And these are, again, just what we talked about. Gas exchange kind of summarizes what we talked about. Respiratory drive primarily stimulated by the concentration of hydrogen ions in arterial blood gases. I won't get into that because we will talk specifically about blood gases in 8B when we talk about oxygenation. Chronic obstructive pulmonary diseases, alveolar damage limits exchange of O2 and CO2, CO2 retention, decrease in blood O2 levels. These are just what is characterized, what kind of respiratory problems the patients will have when they have COPD, retraction, cyanosis, club nails. And these are reasons why you might see alterations in those VQ ratios. Airway and alveolus is blocked by sputum, inflammation, atelectasis, and fluid volume excess. Blood flow in capillary blocked by blood clots, plaque buildup, and emphysemic alveoli. And then, as I talked about, airway patency. Okay. And these are the respiratory patterns, just as I talked about these. Okay. Know what apnea is, know what dyspnea is. It is just basically shortness of breath, but you can have a spectrum of dyspnea where someone are mildly dyspneic, or people that are severely dyspneic where they have dyspnea, just at rest. Orthopnea is difficulty breathing when supine. So if you see your patients lying down and you know that they're extremely short of breath, it's very important that you don't lay them down, especially when you have to pull them up, because they will not be able to tolerate that. This is why a lot of our respiratory patients, you might see them sleeping in a chair, because the chair might be elevated and it's just easier for them to breathe, and this is the only way they're able to sleep. again, know these different types of breathing patterns, Kussmaul, Cheyne-Stokes, Bayet, and how medications such as a lot of our opiates can cause respiratory depression. Okay. These are some of the other concepts related to oxygenation, but we're just looking now at the concept of oxygenation. On Wednesday we'll look at perfusion. Okay. These are factors that affect healthy respiratory systems. Some of airborne irritants, maybe people are allergic to pollen in the air, cigarette smoke, chemicals, pollution. People get sick and they develop infections of the respiratory tract. Hemoglobin disorders, patients develop anemia. Some medications affect respiratory rate and depth. And of course, inflammation, infectum, sputum production, compromised airflow, alter respiratory health. Management of environmental air quality may decrease concentration of respiratory irritants. This is why we encourage anyone over 65 years of age and anyone who has a chronic illness to receive vaccines that are to help decrease the transmission of preventable diseases such as pneumonia. Some of the modifiable risk factor, we've talked about this, but this is again things to look at in regards to why people get sick in their respiratory system. Factors affecting heart's ability to circulate blood, hypertension, atherosclerosis, obesity, type 2 diabetes, smoking, and of course stress and anxiety. Looking at our assessments of subjective, objective, and signs of hypoxia. These are a lot of the early types of signs where they start to get restless. If you see a patient start to become very fidgety, always assess their respiratory status. They become irritable, or just all of a sudden they're confused. They don't know where they're at. This could be a lack of oxygen, okay? And along with that, you're going to see, the heart working harder now because it has to push oxygen throughout the body as best as it can. And I said these two systems work very closely in conjunction with each other. So you'll see the heart rate go up and the respiratory rate go up because it's trying to keep those patients oxygenated. It's kind of like the compensatory effect that happens when people develop hypoxia. Of course, knowing your patient's health history with all these, I'm not going to go over those in detail. Physical exam, observation. This is that visual assessment where we look at the patient and then we auscultate and then palpate. We aren't percussing here in Nursing 100, and these are adventitious breath sounds. These are the abnormal ones. Does the patient demonstrate stridor, crackles, rhonchi, wheezing, or a pleural fiction rub? How does the patient present? How's his posture? Is he leaning over the bedside trying to open up those airways, or is he having difficulty speaking or breathing, and is his voice very raspy? Okay, those are clues that the patient is in some kind of respiratory distress.